It's a privilege to have the opportunity to present to you this two-part discussion of breast cancer cryoablation, a practical guideline for patients and physicians. I'm Dennis Holmes. I'm a breast cancer surgeon and clinical researcher based in Glendale, California and Los Angeles. First of all, to help you understand why I would have the authority to write a guideline for cryoablation patients and their doctors, I'd like to share with you a bit of my background. You see, I first learned about cryoablation in 2002 when I was training to become a breast surgeon, which was at a time when cryoablation was being promoted as an alternative to surgery for treatment of a particular type of benign breast tumor called a fibroadenoma. However, upon learning about cryoablation, I immediately became interested in it as a potential treatment for breast cancer, and I set about the task of learning how to master it with the objective of using cryoablation in the future as a treatment for breast cancer. My process began with the establishment of a minimally invasive breast biopsy clinic where I not only learned how to perform cryoablation on fibroadenomas, but I also taught breast surgeon trainees how to do it, culminating in this publication in 2006 titled A Minimally Invasive Breast Biopsy Clinic, an innovative way to teach breast fellows how to perform breast ultrasound and ultrasound-guided breast procedures. I then went on to build my experience in breast cancer cryoablation through collaborations with several pioneers in cancer cryoablation, beginning with Dr. Fukuma from Japan, who had already been performing cryoablation on breast cancer for several years. Here's an image from my first visit with him in 2009. I also had the opportunity to spend time with Dr. Korpan of Austria and Dr. Xu of China, who for years had been performing cryoablation on multiple different cancer types, and together literally wrote a book on the topic. Following my return from Japan, I became a co-investigator in the ICOSG Z1072 clinical trial, which was the first multi-center trial of cryoablation in the U.S., which aimed to determine the effectiveness of cryoablation. The trial was open to women with stage 1 breast cancer, specifically invasive ductal cancers measuring 2 centimeters or smaller, as assessed by mammography, ultrasound, and breast MRI. In addition, the trial was what we called a cryoablation followed by surgery trial, which meant that patients underwent cryoablation and then approximately 1 month later underwent either a lumpectomy or mastectomy to remove the cryoablation site. The goal was to determine whether or not there would be any residual cancer cells in the site that was previously ablated. 99 patients were enrolled in the study between 2009 and 2013, and the results of the study were published in 2016, which showed complete tumor kill in 100% of tumors less than 1 centimeter in size, and 92% of tumors 2 centimeters or smaller. So what do we learn from the trial? We learned about the types of breast cancers that are best suited for cryoablation, namely invasive breast cancers with not too much coexisting ductal carcinoma in situ. We learned the importance of high-quality breast imaging to clearly define the extent of cancer. And we learned the importance of experience in interpreting breast ultrasound and the importance of experience performing ultrasound-guided breast procedures, the lack of which accounted for several cases of cryoablation failures in the study. After completing the ICOSG clinical trial, I launched the FROST trial, which is an acronym for Freezing Alone Instead of Resection of Small Breast Tumors. The FROST trial was open to women with stage 1 invasive breast cancer measuring 2 centimeters or smaller. The trial was the first U.S.-based study of cryoablation without surgery, where instead of having surgical removal of the cryoablation site, patients underwent a needle biopsy of the cryoablation site 6 months after cryoablation to document the absence of residual cancer. The trial is now closed to enrollment. Data are being collected and analyzed, and I plan to publish the study's results later this year. And most recently, I opened the DCIS cryoablation trial, which is one of the first trials in the world to examine the use of cryoablation for managing DCIS, or ductal carcinoma in situ, which is different from invasive breast cancer in that DCIS is not usually ultrasound visible, as I will discuss later in this presentation. So through this 2 decades long experience of raising and watching cryoablation grow up, metaphorically speaking, as a treatment for breast cancer, you can now understand why I feel a parental relationship with breast cancer cryoablation. And like any good parent, you feel a responsibility to guide your child in finding a purpose in life, to help your child overcome challenges he or she might experience in the world, to educate your child, or rather to advocate for your child against detractors, but also encourage your child to dream while also setting reasonable boundaries to maximize the odds of long-term success. So it is with this perspective that I present this 2-part discussion of breast cancer cryoablation, a practical guideline for patients and physicians, which, as you see, is available in video format, but will also be published in print format. The goals of the guideline are the following: to educate patients and healthcare providers about cryoablation and about how it fits into the entire breast cancer treatment spectrum, to educate surgeons and radiologists to help them learn the easy way things that have taken me 20 years to learn. The goal is to advocate for patients seeking cryoablation or for those who have already received cryoablation who are seeking guidance. The goal is to advocate for cryoablation as a treatment for breast cancer while also pointing out its limitations. And last but not least, I wanted to create a comprehensive printable document that patients could read, highlight, and use in a more practical way, including sharing it with family and friends or sharing it with their doctor if the doctor is interested in learning about cryoablation. So if you'd like to receive a printed copy of the manuscript, you can download it from my website, www.cryoablation.com, or find it elsewhere on the internet. As I mentioned, this is a 2-part presentation. The first part of the presentation will discuss initial diagnostic workup and pre-treatment planning, and the second part will discuss treatment approaches and post-treatment follow-up. The second part will be included in a separate video, and the first part is included in this video. So what is breast cancer cryoablation? Breast cancer cryoablation is a minimally invasive procedure that uses extremely cold temperatures to kill cancer cells. Over the last 15 years, cryoablation has emerged as an office-based, minimally invasive alternative to breast cancer surgery for managing breast cancer. The main aim of cryoablation is the destruction of a breast cancer along with a surrounding margin of normal breast tissue, which is comparable to what we aim to achieve with lumpectomy. With cryoablation, we aim to ablate the cancer, shown here in red, with a surrounding 5 to 10 millimeter margin, utilizing a 4 by 3 by 3 centimeter cryoablation zone of necrosis, shown here in gray, which is the actual volume of tissue that's killed. And this is accomplished by creating a 5 by 4 by 4 centimeter ice ball, shown here in blue, using liquid nitrogen, which freezes the core of the cancer down to minus 185 Celsius. And just like lumpectomy, cryoablation may be followed by anti-cancer medications or radiation therapy, depending upon the circumstances. Several potential advantages make cryoablation an appealing alternative to lumpectomy. In the context of patient-centered care, cryoablation expands the breast cancer treatment options for patients seeking to avoid traditional surgery because of philosophical motivations, competing health concerns, or other reasons. As an office-based procedure performed with local anesthetic, cryoablation minimizes or eliminates the potential side effects of breast surgery, like a symptomatic seroma, a hematoma, or infection. It also eliminates the side effects commonly associated with general anesthesia, such as nausea, vomiting, or possibly worsening of cardiopulmonary conditions. Compared to breast cancer surgery, cryoablation has a minimal impact on patient quality of life and permits early return to work and daily activities. Like lumpectomy, cryoablation does not involve the excision of breast tissue. Unlike lumpectomy, cryoablation does not involve the excision of breast tissue, and thereby eliminates or minimizes the potential cosmetic side effects of tumor excision. In this way, cryoablation is the ultimate cosmetic solution for breast cancer that eliminates the need for preemptive or corrective surgical procedures aimed at maintaining or restoring breast volume, contour, and symmetry. So what's the evidence supporting the use of cryoablation as a breast cancer treatment option? First of all, you should understand that there are currently no published randomized controlled trials or other comparative studies directly comparing cryoablation to lumpectomy, which is the gold standard for breast cancer studies, these comparative studies. However, 2 prospective comparative studies are currently underway or in development. The first one, the one that's underway, is a single-center prospective randomized controlled trial at Washington University in St. Louis that aims to enroll 256 participants who will be randomized equally to either cryoablation or lumpectomy. Participation in the study will be limited to women aged 50 and older, with stage 1, low to intermediate nuclear grade, luminal A type invasive ductal carcinoma that are estrogen receptor positive and or progesterone receptor positive but HER2 negative. Although there are no completed comparison studies of cryoablation versus lumpectomy, there is a published study that's a single-arm study looking at the effectiveness of cryoablation in patients with early-stage breast cancer. This was a study of cryoablation without excision for low-risk early-stage breast cancer, which published its results, its 3-year follow-up results in 2022. The study enrolled 194 patients aged 60 and older. All patients had unifocal breast cancer, meaning the cancer is present in only one spot. They all had ultrasound visible tumors measuring 1.5 centimeters or smaller. All patients were either estrogen receptor positive or progesterone receptor positive. They were all HER2 negative, and they all had breast size that was suitable for safe administration or safe cryoablation. At the discretion of the treating physician, 27 patients received adjuvant radiation in addition to cryoablation. 148 patients received endocrine therapy or anti-estrogen therapy, and 1 patient received chemotherapy. At the end of the 3-year follow-up period, it was determined that there was a 2% local recurrence rate, which is comparable to what we would generally see with lumpectomy, which established a trial, at least at this point, as one in which cryoablation is one demonstrating the ability of cryoablation to be safely administered with a low risk of recurrence at 3 years. We also have early data from the FROST study, which I mentioned earlier, is a single-arm study of cryoablation without surgery, in which a 1% local recurrence rate was observed at 3 years follow-up. As I mentioned, I'll be updating the results of the study later this year. And there's also unpublished data from Dr. Fakuma showing a 1% local recurrence rate at 6 years follow-up. Although Dr. Fukuma's study results are excellent, you must understand that the study was limited to women with stage 1 breast cancer measuring 1.5 centimeters or smaller. All tumors were low to intermediate grade. All tumors were either estrogen receptor positive or progesterone receptor positive, and none were HER2 positive. It's also important to know that after cryoablation, all patients in the study underwent a lymph node biopsy, they received anti-estrogen therapy, and they also received whole breast radiotherapy. So it was a comprehensive breast cancer treatment that yielded this 6-year local recurrence rate of 1%, which again was excellent, but it was with comprehensive breast cancer care, not just cryoablation alone. Now, in addition to using cryoablation to treat the typical stage 1 breast cancer, there are other possibilities for cryoablation that I wrote about in a publication that you see here. In addition to using cryoablation as a definitive treatment, there's also the possibility of using it as a stopgap measure in the management of stage 0, stage 2, stage 3, and stage 4 breast cancer. And patients may opt for cryoablation when either they're unwilling to have surgery or when, in the case of a pandemic, healthcare resources are limited and patients aren't able to access the typical therapy that they receive, that they would receive outside of a pandemic. Like, for example, in the last pandemic, patients were having challenges accessing surgery because operating rooms weren't fully functioning, and medical hospitals significantly reduced elective surgery. Again, cryoablation would be perfect for that scenario, but it also is perfect outside that scenario. So as I discussed in the article, Breast Cancer Care During a Pandemic, an Opportune Time for Cryoablation, published in 2021, there are multiple breast cancer scenarios for which cryoablation might be considered, including the use of cryoablation as a definitive therapy, where cryoablation of the cancer is performed without a plan for subsequent breast surgery, or it can be used as a stopgap therapy, which refers to the use of cryoablation as a temporary solution prior to anticipated surgery, like when a cancer might be ablated to prevent further growth or spread, while the patient is still trying to decide what to do, perhaps lumpectomy, perhaps mastectomy, or while the patient is still waiting consultation, say with the plastic surgeon, to determine what type of reconstruction she might have performed. Instead of allowing the cancer to grow while these delays are experienced, cryoablation of the tumor could be used to prevent further growth and spread while the patient is going through this decision-making process. Now, if you'd like a copy of this publication, you can find this journal article on my website, cryoablation.com, or you can find it on the internet. Now, let's say you were being considered for cryoablation. Just as with surgery, every cryoablation candidate should undergo or be offered appropriate pretreatment assessment. As Alexander Graham Bell famously said, before anything else, preparation is the key to success. So first of all, you should understand that the last 2 decades have seen tremendous improvement in breast cancer survival rates, as evidenced by decreased breast cancer deaths, among other things, as shown in this graph. Although a major source of this improvement, or this progress, has been the early detection and timely management of breast cancer, other key factors for these improvements include an enhanced understanding of tumor biology, the use of targeted anti-cancer medications based on tumor biology, as well as the adoption of evidence-based diagnostic and treatment protocols that prioritize evidence-based practices while also eliminating interventions with minimal cancer control benefits. A common characteristic among patients seeking cryoablation is a desire to avoid standard approaches for treating breast cancer. However, proper informed consent requires that patients understand the role that these treatment options play in their overall care and prognosis. A major hazard faced by patients seeking non-standard breast cancer therapy is that they often are left to navigate themselves along a complicated cancer journey without the steadfast guidance and support of an experienced breast surgeon, surgical oncologist, medical oncologist, or team of cancer specialists. As a result, these patients often have an inadequate understanding of their extent of cancer. They often have an inadequate understanding of the risk of recurrence. They often have a poor understanding of the benefits and risks of various treatment options. They often experience a fragmented course of care with a lack of appropriate coordinated specialist referral, even if the specialist's recommendations will ultimately are likely to be declined by the patient. They commonly experience underuse of genomic and genetic testing and overuse or underuse of appropriate cancer staging studies. While it is true that many patients seeking standard treatment options may also experience these same hazards, for cryoablation patients, exposure to these hazards depends largely on who performs a cryoablation procedure, a surgeon or a radiologist, and whether or not that individual is directly or indirectly accountable for facilitating the patient's overall cancer care. In my informed opinion, the major advantage of seeking cryoablation from a breast surgeon or surgical oncologist is that these cancer specialists customarily assume the responsibility or accountability for not only treating the cancer, but also coordinating all aspects of the patient's initial phase of breast cancer care. This begins with bringing a surgeon's mindset to the cryoablation procedure in terms of mapping the extent of the cancer and planning a cryoablation treatment approach that places a premium on achieving clear margins. As accountable providers, breast surgeons and surgical oncologists routinely determine the proper sequence of care. Sometimes they recommend surgery first. Sometimes they recommend upfront chemotherapy and or anti-estrogen therapy or anti-HER2 therapy. These specialists also order and interpret genomic testing when appropriate and perform genetic counseling and testing when appropriate. Surgeons routinely order the appropriate staging studies, discuss and or perform the surgical alternatives to cryoablation, including lumpectomy or mastectomy with or without reconstruction. They determine the most appropriate management of the lymph nodes and perform lymph node surgery if needed. They typically conduct detailed and extensive patient counseling about the entire cancer treatment spectrum. They refer to and coordinate care with medical oncology, radiation oncology, and functional medicine. And they prescribe, as in certain circumstances, medications that are appropriate for the cancer. For example, anti-estrogen therapy to temporize a cancer while awaiting treatment, or anti-estrogen therapy as a follow-up to treatment. Surgeons also order follow-up imaging and provide long-term clinical breast examinations. Thus, by doing all of these things, surgeons play a coordinating or quarterback role in treating the cancer and managing the initial phase of the cancer journey, as compared to radiologists who are primarily focused on the technical aspect of treating the cancer without taking part in other things, with the other things that I mentioned, or at least not taking part in them to the degree that is required for a patient facing a potentially life-threatening diagnosis. Ultimately, the long-term success of cryoablation depends less on the cryoablation procedure itself, but more on all the steps that are done to assess and minimize the risk of recurrence. So for a patient considering cryoablation, amongst the most important questions she should ask and have answered in the initial consultation with the specialist is whether or not the cryoablation provider will share responsibility for coordinating the initial phase of her cancer care. If the answer to the question is not a convincing yes, then in my opinion, the patient would be wise to seek care from another cryoablation provider. However, to make sure all of the I's and T's are dotted and crossed, I prepared a checklist of things that should be considered for all cancer patients, including cryoablation patients. The checklist is divided into 3 sections: initial diagnostic workup, pre-treatment planning, and post-treatment follow-up. I will discuss each of these sections in the remaining presentations. The first item on our checklist is mammography. Breast cancer staging should include bilateral digital diagnostic mammograms, preferably in the form of 3D mammography or tomosynthesis, and this is done to evaluate the extent of disease. Although cryoablation is generally performed under ultrasound guidance, high-quality mammograms might actually reveal additional findings, additional areas of disease that impact how cryoablation is performed, or whether or not the patient is even a reasonable candidate for cryoablation. For example, mammograms might reveal multiple cancers in the same breast. It could reveal spiculations or radial extension of the tumor that would need to be addressed, either with cryoablation or surgery. Or it might identify additional calcifications outside of the main tumor mass, which would also need to be managed. Consequently, even patients who are generally opposed to obtaining screening mammograms should be encouraged to have at least one set of pre-treatment diagnostic mammograms, given the importance of mammography in potentially detecting additional cancer or cancer characteristics that need to be incorporated in the treatment or that might impact the patient's, the doctor's recommendations regarding the appropriateness of cryoablation. Breast ultrasound should be performed to confirm eligibility for ultrasound-guided cryoablation. In addition to assessing the closeness of the tumor to the skin and chest wall, ultrasound can reveal the presence of tissue changes surrounding the more obvious portion of the tumor, or extension of the cancer into the adjacent ducts, like the examples that I've shown here, either of which would influence how cryoablation is performed. Just to explain that once again, you see the upper image, you see the sort of dark central area, which is sort of the obvious components of the cancer, but what also should be included in the treatment of this cancer is this edematous border, which is also an area where disease might be present and needs to be incorporated into the cryoablation treatment. In the second example, you see again the obvious tumor mass, but you also see next to the arrow extension of the tumor into a duct to the right of the tumor, as well as a duct to the left of the tumor. Again, treatment of the tumor requires incorporation of these ductal extensions as well into the treatment zone. Ultrasound of the nearby underarm or axillary nodes permits detection of abnormal appearing nodes that might not be detected on physical examination, mammography, or breast MRI. Axillary ultrasound is the most sensitive imaging study for detection of subtle changes in the shape or thickness of a lymph node that might indicate the presence of lymph node metastasis. Detection of suspicious nodes determines clinical cancer stage and requires a specific plan to manage the possibility or potential consequences of a lymph node metastasis. In this image, you see a normal node, which contains fat in the center, which is represented by this white area, and generally has a thin cortex, which is shown by this dark area. However, in this example of an abnormal node, although there's some preservation of fat, what you see is a normally thin cortex here, which is now distorted by this bulbous distension, which likely indicates the presence of a metastatic deposit growing within the node. This node should be biopsied in order to be sure that this patient does not have metastatic disease. And if she does, it should be biopsied so that it can be managed appropriately. Contrast-enhanced breast MRI improves assessment of tumor dimensions, but requires the use of an intravenous contrast agent called gadolinium. Patients unwilling or unable to receive gadolinium might be able to undergo dedicated breast-only diffusion-weighted MRI, which has limited availability in the U.S. Whole-body diffusion-weighted MRI does not have sufficient resolution for breast cancer evaluation and treatment planning. The contrast solution, gadolinium, permits visualization of the blood vessels within the breast, including small blood vessels inside of the breast cancer that make the breast cancer more readily detectable. In this image, you see prominent vessels because of the infusion of gadolinium, but you also see two areas of invasive cancer, or two areas of cancer, that enhance compared to the background. Enhance meaning they have increased blood flow, and they are detectable by their retention of the gadolinium, which makes them glow or appear white on this breast MRI. Breast MRI also improves detection of speculations, shown here as these radial extensions from the dominant tumor mass. There's one speculation. There's another speculation here. MRI might also reveal areas of multifocal or multicentric cancer outside of the dominant mass. Again, this is the dominant cancer mass shown here, but there's one small focus of tumor here and another focus of tumor here, establishing this as a multifocal cancer. And since breast MRI is used to perform on both breasts at the same time, it also improves detection of contralateral breast cancer or cancer in the other breasts. All of these findings might impact eligibility for cryoablation, or at least how cryoablation is performed to accomplish complete treatment of the areas where disease is identified. Contrast enhanced breast MRI also has the added value of allowing 3D reconstruction of images and image rotation, as well as image rotation, to permit viewing of the tumor from different angles for a more comprehensive assessment of breast tumor shape and dimensions. You got an impression of that a moment ago when you saw the video rotate. I'll show it to you again. With rotation of the images with the MRI, you're able to see the tumor in multiple directions to have confidence about its three-dimensional structure, so that when cryoablation is performed, all of the features of the cancer can be incorporated completely within the cryoablation zone. Thermography aims to detect cancer by using an infrared camera to capture heat that is emitted from an underlying cancer. Some cryoablation candidates express a preference for thermography over mammography to avoid radiation and breast compression, which is required for mammography. Despite these advantages of thermography, multiple studies comparing thermography to mammography or thermography to ultrasound found thermography to be inferior to both mammography and ultrasound for detection of breast cancer. In any case, any suspected cancer detected by thermography should be further evaluated with mammography and ultrasound to characterize the extent of disease and to guide a diagnostic needle biopsy procedure, as well as to assess the cancer's suitability for ultrasound-guided cryoablation. Breast needle biopsy targeting the breast tumor should be performed under mammogram guidance, ultrasound guidance, or MRI guidance, depending upon the imaging studies that best show the cancer. The goal of the needle biopsy is to establish a clear diagnosis of cancer and to confirm or exclude the presence of multifocal or multicentric disease if suspected. Insertion of a biopsy site marker, which is also called a clip or chip. Insertion of the marker at the location of the breast abnormality is recommended at the time of the needle biopsy procedure to document the site of the biopsy regardless of tumor size. In situations where pre-cryoablation chemotherapy and/or anti-HER2 therapy is planned, Insertion of a biopsy site marker prior to initiation of anti-cancer medications documents the location of the tumor. In the event treatment-induced shrinkage of the cancer makes the cancer difficult to detect by ultrasound. In breast radiology, the most commonly used biopsy site markers are metallic markers that are designed to be viewed by mammography, not by ultrasound. And as you can see from this image, these markers come in multiple shapes and sizes, but most are the size of a grain of rice or smaller. For tumors that are readily visible by ultrasound, the type of marker does not matter, as the tumor itself provides an obvious target for ultrasound-guided cryoablation. However, when the breast abnormality is very small, or when it is invisible to ultrasound, insertion of an ultrasound visible marker at the time of the initial needle biopsy will facilitate ultrasound-guided cryoablation without the need for insertion of an ultrasound-guided marker, an ultrasound visible marker, in a separate procedure at a later date. In this image, you see an example of an ultrasound visible marker. These two parallel white lines are the ultrasound representation of this collagen basket, which is the feature of the marker, which allows it to be detectable by ultrasound. The marker also has a metallic part, but again, the part that allows it to be detectable by ultrasound is this absorbable collagen part, which is shown on the ultrasound as these two parallel white lines. The last point I wanted to make on this slide is that although there is no evidence linking a needle biopsy procedure itself with a reduction in breast cancer survival, there is compelling evidence that a delay as short as 3 months between abnormal imaging and a positive diagnostic needle biopsy results in a 20% relative reduction in overall survival. Thus, delays in a diagnostic workup of suspected cancer can directly increase the opportunity for cancer spread among the very same patients who are seeking to minimize spread by avoiding a needle biopsy. So the consequences of avoiding a needle biopsy, unfortunately, often ends up delaying a diagnosis of breast cancer, and that delay can compromise the survival. That's the point of this publication. So my recommendation, therefore, would be if there is a suspicious finding seen on breast imaging, timely biopsy should be performed so that the patient can move forward with whatever appropriate therapy they're comfortable with, because the delay itself is a problem, not just the needle biopsy. Now let's shift to discuss ductal carcinoma in situ, or DCIS. DCIS is a non-invasive form of breast cancer in which the cancer cells are confined to the milk ducts and haven't yet developed the ability to spread to the lymph nodes or elsewhere. DCIS is usually detected as microcalcifications or calcium deposits that form within the milk ducts as a form of these calcium deposits form in the milk ducts as some of the cancer cells die and get fossilized. So basically, calcifications are cancer fossils. Fortunately, these calcifications may be readily detected on mammography as tiny white specks, a fraction the size of a grain of rice. Actually, a fraction of the size of a grain of salt. Although in this image they look quite large, you should know that in this image they've been greatly magnified. But what it shows is a calcification within a distended duct that is lined internally by cancer cells. So this is a case of DCIS containing a calcification. And mammographically, this calcification would appear as this white speck on mammogram, which allows the DCIS to be detected. Remember, the mammogram in this case does not actually see the DCIS, What it sees are calcifications that then draw attention to the possibility of DCIS. A biopsy of the calcifications, when examined under the microscope, would potentially or could potentially reveal this diagnosis of DCIS, and that's how the diagnosis is typically made, following a stereotactic biopsy, as you call it, or a mammographically guided biopsy of calcifications. Now, when it comes to treating DCIS with ultrasound-guided cryoablation, the problem with DCIS is that neither the cancer cells nor the calcifications are usually visible by ultrasound, which is why DCIS has for the most part been excluded from all previous studies of cryoablation. However, as you've learned, we do have the ability to insert an ultrasound visible marker at the site of DCIS to make it an ultrasound visible target for cryoablation, which is exactly why we're taking on DCIS in this clinical trial that I'm currently conducting, titled Prevention of Invasive Breast Cancer with Cryoablation. You see, the main reason that we treat DCIS is to prevent it from developing into invasive breast cancer. If not for this risk of development into invasive cancer, DCIS would never require treatment. Currently, surgery is the main tool we have for treating DCIS, but in this trial, I'm evaluating the ability of cryoablation to achieve complete ablation of DCIS to eliminate the need for surgery. The trial will also examine the 5-year local recurrence rate of invasive breast cancer after treatment of DCIS. The study is open to women aged 18 years and older, with a single area of DCIS measuring 2 centimeters or smaller that is assessed by mammography and is assessed by an optional MRI, which is not required but is optional in this study. In this study, all patients undergo insertion of an ultrasound visible marker at the site of DCIS, as shown in this image once again. Marker placement is then followed by cryoablation of the DCIS site, followed 6 months later by a needle biopsy of the cryoablation site to document complete DCIS kill. And then the patient returns to annual mammograms. Ultrasound-guided core biopsy of suspicious X-ray nodes should also be performed to either document or rule out metastasis to the X-ray nodes. Insertion of an ultrasound visible biopsy site marker at the time of the initial biopsy or subsequently will facilitate ultrasound-guided cryoablation, or ultrasound-guided excision of the lymph node should it become less detectable after the biopsy or after pre-cryoablation anti-cancer therapy. In the not-too-distant past, cancer biomarkers or cancer receptors or cancer prognostic markers, all those terms define the same thing: biomarkers, prognostic markers, or receptors. But in any case, in the not-too-distant past, cancer biomarkers were commonly completed or analyzed in the tissue removed at the time of surgery. However, the new standard is for these biomarkers to be measured in the needle biopsy specimen that is obtained before treatment. For example, before cryoablation or before surgery, because these biomarkers can determine how the patient should be optimally managed. The biomarkers we look for in breast cancer are estrogen receptor and progesterone receptors. These are tested routinely in both invasive breast cancer as well as in DCIS. HER2/neu is another receptor that is routinely tested in invasive breast cancer, but not routinely tested in DCIS, since it does not influence how DCIS is managed. Ki-67 is yet a fourth biomarker that is routinely tested in the core sample or the needle biopsy samples that we obtain prior to surgery. Based upon receptor type, about 65 to 75% of patients are estrogen or progesterone receptor positive, about 15 to 20% are HER2/neu positive, and about 15 to 20% are triple negative in that they lack all three of the key receptor proteins: estrogen receptor, progesterone receptor, and HER2/neu. Ki67 is not a receptor per se. It's actually an expression of the number of cells that are observed to be in the process of multiplying. So it's a percentage of the cells that are actively dividing as assessed by the pathologist under the microscope. Measurement of cancer biomarkers in a needle biopsy specimen prior to surgery or cryoablation has implications for how the tumor is treated, particularly for invasive breast cancer. For example, for an invasive breast cancer that is HER2/neu negative and estrogen receptor positive or progesterone receptor positive, which is a profile of most invasive breast cancers we see today. For these patients, the first course of treatment is upfront surgery or upfront cryoablation, followed by drug therapy, unless genomic testing, which we'll describe later, or the clinical scenario suggests a clear benefit for receiving upfront chemotherapy. On the other hand, invasive breast cancers that are HER2/neu negative, estrogen receptor negative, and progesterone receptor negative, what we call triple negative, are generally treated with upfront chemotherapy if they are greater than 1 centimeter in size or node positive, with potential for that treatment sequencing to improve patient survival. That's why chemotherapy is usually given to these patients first, because evidence shows that survival is improved when it's sequenced first as opposed to when it's given after surgery or after cryoablation. The same thing is true for patients with HER2/neu positive breast cancer. Regardless of the estrogen receptor status, these patients are generally advised to have upfront drug therapy, including chemotherapy and anti-HER2/neu therapy, if the tumor is more than 2 centimeters in size or if the tumor is node positive. Let me explain to you genomic testing. Genomic testing, which I referenced on the previous slide, which is kind of described in lay terms as tumor gene testing. We're testing the tumor's genes. Genomic testing, or tumor gene testing, is performed as an important tool for estimating the 5-year or 10-year risk of recurrence of breast cancer. Genomic testing may be performed on a needle biopsy sample or on the tissue removed from the time of surgery. This slide shows the 4 genomic tests that are commercially available today. Actually, there may be other tests available, but these are the 4 genomic tests that are included in the National Comprehensive Cancer Network guidelines. Tumors may be categorized as either low risk, intermediate risk, or high risk for recurrence, depending upon the score that they receive from the various genomic tests. As indicated on this slide, genomic testing is only performed on hormone receptor positive but HER2 negative breast cancers, because triple negative invasive breast cancers and HER2 positive invasive breast cancers always have a high risk score for which chemotherapy is indicated. So it's the estrogen receptor positive or progesterone receptor positive but HER2 negative breast cancers that are appropriate for genomic testing. So usually we'll get the results from the core biopsy back first to determine if the tumor meets these criteria. We want to confirm that the tumor is estrogen receptor positive or negative, progesterone receptor positive or negative, but HER2 negative. They need to be HER2 negative. And if they are, then the patient is a candidate for genomic testing, which would then be ordered as a separate study to be analyzed using the tissue samples that were obtained at the time of the needle biopsy. Although the primary aim of genomic testing is to determine whether chemotherapy improves breast cancer survival in a patient who is expected to be treated with anti-estrogen therapy, estimation of the risk of recurrence can also influence the decision making of a cryoablation candidate who is considering skipping anti-estrogen therapy or chemotherapy altogether. For example, a genomic recurrence score showing a high risk of recurrence might motivate a patient to accept chemotherapy or at least to remain compliant with anti-estrogen therapy. Conversely, a low-risk recurrence score confirms a lack of benefit of chemotherapy and might also reduce the anxiety of a patient who has elected to decline or limit the duration of anti-estrogen therapy. Since all patients with triple negative or HER2 positive breast cancer would receive a high risk score by genomic testing, again, there is no role for genomic testing to estimate the risk of recurrence in these patients. I'll now move on to discuss cancer staging. The principles guiding breast cancer staging for cryoablation patients should mirror the most recent version of the National Comprehensive Cancer Network guidelines that we call what we call the NCCN guidelines. The most recent NCCN guidelines recommend whole body scans for distant spread only for patients with stage 3 or stage 4 breast cancer. For those with stage 0 or 2 breast cancer, the NCCN guideline recommends body scans only if there are symptoms like headache, physical findings like weight loss, or abnormal liver laboratory studies. Routine staging for stage 3 and 4 breast cancer may consist of CT scans or computed tomography focused on the chest and abdomen with or without pelvic scans, or a PET scan, which is called a positive emission tomography scan, for detection of metastasis in the lung, liver, or other organs. Although many bone metastasis may be detected on a PET CT scan, dedicated staging for bone metastasis may be accomplished with a nuclear medicine bone scan or something called a sodium fluoride PET CT scan. For all other patients, imaging should be based on signs and symptoms. For example, a chest CT with and without contrast to evaluate a cough or shortness of breath. For a patient with abnormal liver laboratory studies or nausea or abdominal pain, they should be evaluated with an abdominal and or pelvic CT. An abdominal plus minus pelvic CT, including contrast, or they may be evaluated by breast MRI to determine if there's any liver disease. Someone who's having back pain might benefit from a spine MRI with contrast. Bone scan or sodium fluoride PET CT may be obtained for bone pain, and brain MRI may be used to assess headache or dizziness. Chest X-rays, although they are used or have been used a lot in the past, and the guidelines indicates that chest X-rays are not recommended for breast cancer staging. The laboratory studies, CBC, a complete metabolic panel called CMP, and liver function tests, LFTs, are only recommended if the patient is considering anti-cancer medications, either chemotherapy or anti-estrogen therapy, for example. We'll now switch gears and take a look at genetic testing. First of all, the figure that you see here shows that the vast majority of breast cancers are chance events. They're called sporadic breast cancers. That is represented by the green portion of the sphere. However, about 5 to 10% of breast cancers, the blue edge, are hereditary breast cancers, which not only influence how the patient might be treated, but also tells us that their family members are also at risk of breast cancer or other mutation-related cancers, depending upon the specific type of mutation that they have. Therefore, given the importance of a positive result terms of its impact on the patient's management as well as its impact on the patient's family's management, it is essential that we strive to identify all patients with a genetic predisposition to developing breast cancer. With this aim in mind, the current NCCN guideline recommends genetic counseling and testing for all women with triple-negative invasive breast cancer, as well as all individuals with personal or close family history of breast cancer at age 50 years and younger, a personal history of multiple primary breast cancers, like bilateral breast cancer would be an example of that, or a personal or family history of either ovarian cancer, pancreatic cancer, or high-risk/metastatic prostate cancer. Genetic testing can be performed with either blood sample or saliva sample. A positive genetic test for a hereditary breast cancer mutation does not exclude the patient or eliminate the option of cryoablation for that patient. So what I'm saying is that even if someone has a positive genetic test indicating an elevated lifetime risk of breast cancer, that does not mean that the patient is not a candidate for cryoablation. What's important to know is that even though patients may be mutation positive, if you're talking about an older patient, say 70 years of age, that patient still has only about a 20% lifetime risk, 20% risk of breast cancer recurring again in their remaining lifetime, or occurring in their remaining lifetime. So the probability of having a breast cancer for a mutation positive patient basically depends upon the year at which they're diagnosed. A younger patient could have an 80% lifetime risk of breast cancer, but a 70% patient might have a 20% remaining lifetime risk of breast cancer. It is also known that patients with breast cancer mutations have a higher risk of recurrence. They have a higher risk of their first cancer, as well as a higher risk of recurrence of cancer. So this needs to be incorporated, this potential for high risk of recurrence needs to be incorporated into the informed consent discussion so that the patient acknowledges that they are at higher risk. And with that information, they might be more strongly encouraged to consider anti-cancer medications or radiation to reduce the risk of recurrence. Among hereditary breast cancer patients that are candidate for chemotherapy, a positive mutation indicates a likely sensitivity to a medication called a PARP inhibitor. It could also indicate increased sensitivity to platinum-based chemotherapy agents, which, when administered, has the ability to increase the effectiveness of chemotherapy to these agents. So, a gene mutation, and the point I'm making here is that it has implications for guiding treatment. Mutation-positive patients are advised to have PARP inhibitors if they're having chemotherapy, as well as platinum-based chemotherapy agents like carboplatin, because cancers that have a mutation are more sensitive to these particular agents, chemotherapy agents. Lastly, a positive genetic test should also trigger referral of the patient to a genetic counselor for management of other at-risk organs, like potentially, her risk of having ovarian cancer. And it should also trigger counseling of the family members who may also be at risk because they share the same genetics and maybe and might actually turn out to be mutation carriers themselves. So the first-degree relatives of patients that are mutation positive should also consider undergoing genetic testing. Actually, they should also undergo genetic testing to determine if they too are carriers of the mutation. The final topic in part 1 is to discuss the relationship between time to treatment and survival, and the importance of avoiding delays in care. I've alluded to this earlier, but previously the reference was delays in getting to the diagnosis, meaning the delay between abnormal imaging and a positive result. What I'm talking about now is delays in care after a diagnosis of breast cancer has been made. This is an important topic because patients seeking alternatives to standard breast cancer therapy like cryoablation often experience delays of care as they consider or pursue other treatment options. Perhaps they don't know about the options. Perhaps they are delayed in seeing providers, maybe because the provider is out of town and it takes time to travel. There are multiple potential reasons why a patient who has been diagnosed with breast cancer might find some difficulty in finding non-standard treatment options if they're seeking to avoid standard surgery. The concern is that, if these patients delay their care, there are some potential consequences because there's a growing body of evidence that links delayed initiation and completion of cancer care with reduced cancer survival. The survival implications of delayed breast cancer care was brought to light by this publication cited on this slide, that showed a statistically significant 9 to 10% relative reduction in 10-year and 15-year overall survival for each additional 30-day delay when the time interval between a positive diagnostic needle biopsy and surgery exceeds 60 days. So, counting from the date of the biopsy, once you pass 60 days, every additional 30-day delay in treatment causes a 9 to 10% relative reduction in 10 to 15-year overall survival. So time matters, and delaying care does compromise survival because in this time window, tumors have the ability to spread. Even more concerning, the study found that the overall survival reduction disproportionately affected women with stage 1 and stage 2 breast cancer. So it's the early stage breast cancer patients that are at greatest risk of cancer progression due to the delay in care. And it's particularly important sort of socioeconomically because these patients with stage 1 and stage 2 breast cancer represent the largest group of women diagnosed with breast cancer each year. It's also the group for which the survival rate or the prognosis is most promising. So it's a shame when their care and their survival is undermined, since ordinarily you would expect these patients to have excellent long-term outcomes, assuming that they receive efficient care. So based on that study and many studies like it, the three recommendations there are three recommendations that you can draw from these studies. First, patients considering cryoablation should ideally undergo cryoablation within 60 days of their date of diagnosis to avoid compromise in their overall survival. Secondly, patients who remain undecided about standard therapy or whose access to or utilization of standard therapy is delayed. In the meantime, these patients may consider undergoing cryoablation of the breast to prevent ongoing tumor growth and possible spread. This scenario could apply to a patient who is still considering chemotherapy but remains undecided about it, or for a patient who's considering mastectomy but is undecided about which plastic surgeon she might use for cryoablation, or for a patient who might be seeking a second or third opinion. If they're facing delay related to any of these things or to other reasons, travel, childcare, whatever, performing cryoablation as a stopgap measure might be a useful way to prevent tumor growth and spread related to a delay in treatment. A third option available to these patients, especially if they have an estrogen receptor positive or a progesterone receptor positive breast cancer, is that they could be started on anti-estrogen therapy to kind of temporize and prevent tumor growth while they're awaiting the initiation of care, definitive care, whether it's surgery or cryoablation.